Hi guys, the topic for today is the anatomy of the external and the middle ear. So the external ear basically comprises of the pinna, the external auditory canal and the tympanic membrane. Well, if we talk about the embryology of the external ear, the pinna, how is it formed? It is formed by the ridges known as the hillock of his. So here you can see these are the hillock of his, that are condensation of the mandibular and the hyoid arches around the first branchial groove. So the tragus and the anterior external auditory canal is formed by the mandibular arch only. So this is the tragus and the anterior external auditory canal. This region, it is formed by the mandibular arch only. So and the posterior part is formed by the hyoid arch. So anterior by the mandibular and the posterior by the hyoid arch. So any dysfunction in its fusion may lead to certain pathologies, which we will talk later. Now this is the EAC. Anterior EAC is by the mandibular arch, while the posterior by the hyoid arch. The tympanic membrane is derived from all the three germ layers. Now these are the pathologies because of the non-fusion or a disrupted fusion of the hillock of his. This may further lead to the anoxia. The preauricular sinus, the bat ear, or a stenosis or atresia of the EAC. Now let us talk about the anatomy of the external ear. First we talk about the pinna. So this is the pinna. Here you can see this is the helix. So this is the helix. This is the antihelix. Helix, antihelix. This is the tragus. This is the antitragus. This is the intertragic notch. This is the crux of helix. Helix, crux of helix, and the antihelix. This is the crura of the antihelix. This is the triangular fossa. This is the auricular tubercle. This is the scapha. This is the cymba concha, this area. And this is the lobule. So the pinna is a contour made up of the yellow elastic cartilage, the MCQ, covered by fat and the subcutaneous tissue and skin. So the skin, the hair sebaceous and the sudoriferous glands are present. There are two surfaces. This is the lateral surface and one is the medial surface. So as we can see, this is the lateral surface. It is concave with folds and hollows. Skin is firmly attached to the perichondrium on the lateral surface, which is concave. Whereas the convex medial surface, the skin is loosely attached. Now comes the external auditory canal. One need to understand that the external auditory canal, it is not straight. It is S-shaped and the length is 24 mm in length. Well, you can see here, this is the cartilaginous portion, this is the bony portion. So the cartilaginous portion is 1/3, whereas the bony portion is 2/3. In the cartilaginous portion, you will find the hairs and the glands. Where in the bony, there is absence of the hairs and the glands. So it extends from the concha to the tympanic membrane. Outer 1/3 cartilaginous, inner 2/3 is the bony, and the isthmus is the narrowest part. The narrowest portion of the external auditory canal that lies just medial to the cartilaginous and the bony junction. So what is this is the MCQ. The isthmus is the narrowest part, found just medial to the junction of the cartilage and the bony part. So there are two fissures. The fissure of Centorni are present in the cartilaginous part. This is also an MCQ. Here you can see these are the fissures of Centorni. Basically what happens from here, the infection from the parotid and the mastoid basically enters the EAC. So EAC is first directed inwards, backward and upward, and then it goes forward, downward and medially. Now these are the relations of the external auditory canal. So now this is the external auditory canal. Very simple. It is superiorly, if you see, there is a middle cranial fossa. Down we will see there is the jugular bulb, the carotid, the facial nerve, the styloid process, the parotid gland and digastric muscle. Well, if you see posteriorly, the posteriorly is the mastoid ear cells, medially is the middle ear, and outside is the laterally is the outside word. So these are the relation of the EAC, external auditory canal. Now let's talk about the tympanic membrane. It lies at the medial end of the external auditory canal. It is a thin semi-transparent membrane, pearly white in color and oval in shape. So it's not circular, it's oval in shape. The vertical length is 10 millimeters while the horizontal it's 9 millimeters, so with a 0.1 millimeter thickness. Its substance at the acute angle of 55 degrees with respect to the inferior wall of the ESC. So it is not vertically lying. It's not 90 degrees. It's at an angle of 55 degrees with respect to the floor of the ESC. Well, it is a trilaminar structure. Outer layer is the epithelial layer, the middle is the fibrous, also called the pars propria, and the inner is the mucosal layer, which is in continuation with the middle layer mucosa. Two parts are there. There is the pars tensa and the pars flaccida. So the pars flaccida is also called as the Sharpnell's membrane. Then comes the annulus tympanicus. What is the annulus tympanicus? It is the peripheral thicker part of the membrane that is attached at its circumference to the tympanic sulcus. So while doing the surgery, we basically elevate the annulus also, thickest part also. This sulcus ends in the notch called the notch of Ribinus. Now here you can see this is the So what is this? This is the handle of the malleus. So the pars tensa is adherent to this part. The pars tensa is adherent to the handle of malleus. This is the proximal part, distal part. This is the umbo. So from the umbo, there is here you can see the cone of light. So in a healthy tympanic membrane, a healthy pearly white semi-transparent tympanic membrane, you will find this cone of light antero-inferiorly. Then come here is the malleolar prominence. So from here you can see there is an anterior malleolar fold and this is the posterior malleolar fold. Above lies here is the pars flaccida or the Sharpnell's membrane. Here you can see the shadow of the long crest of the incus, the posterior crest of the stapes. This is the promontory, the medial wall of the medially lies the promontory in the middle ear. Then comes the fossa of the cochlear window and the tympanic ring here. Now let us talk about some pathologies, the clinical significance. Here you can see this is a bulging tympanic membrane. There is a perforation in the tympanic membrane and the tympanosclerotic patch. Here you can see the retraction of the tympanic membrane caused by various pathologies. Here there can be a pathology, there can be a fluid in the middle ear which is basically pushing the tympanic membrane forward, which gives a bulging. Here you can see little sort of inflammation, can be seen in the AOM, acute otitis media, can be seen in bulging can be seen in otitis media with effusion where there are air bubbles present. Here you can see the perforation in the tympanic membrane. Here you can see the retraction. The tympanic membrane is adherent to the wall of the promontory. So there are different grading systems. So now comes the blood supply of the external ear. So the pinna in the external auditory canal is supplied by the posterior auricular artery and the superficial temporal artery. Well, if we talk about the tympanic membrane, the outer surface is basically supplied by the mandibular artery and the deep auricular branch of the maxillary artery. Whereas the inner surface, the anterior tympanic branch of the maxillary artery and the posterior tympanic branch of the stylomastoid artery. The inferior tympanic artery branch of the ascending pharyngeal artery and the arteria nutrica, incudomalleal artery, trick from the middle laryngeal artery. Now let's talk about the nerve supply of the external ear. Well, the pinna. So this is the pinna. One need to understand the upper 2/3 on the lateral surface. This is the upper. So we know that a temporal bone lies here on the upper surface. So upper 2/3 is supplied on the lateral side by the auricular temporal nerve, and medial side we know that behind there is the occipital process. So by the lesser occipital nerve. Medially by the lesser occipital nerve and laterally by the auricular temporal nerve, upper 2/3. Well, the lower one third on both the sides is supplied by the greater auricular nerve. Well, if we talk about the external auditory canal, this is the external auditory canal. If we talk of the EAC, the anterior wall, so this is posterior, this is anterior, the anterior wall and the floor. So the anterior wall, this is the EAC. If we make it so this is the anterior wall and this is the floor. It is formed by the auricular temporal nerve. We know already that this area is supplied by the auricular temporal nerve. And the rest of the canal is supplied by the Arnold's nerve. What is the Arnold's nerve? It is the auricular branch of the vagus nerve. Now talk about the tympanic membrane. Again, if this is the tympanic membrane, pars tensa, pars flaccida. So anterior half is supplied by the auricular temporal nerve, the posterior half. So the anterior half is supplied by the auricular temporal nerve, the posterior half is supplied by the tympanic branch of the vagus nerve, and the inner surface is supplied by the tympanic plexus. Now, what is the clinical significance? See the incisura terminalis. Here you can see this part. This is the incisura terminalis. It is an area that is devoid of the cartilage, so it is used for giving the incision safely for the ear procedures, ear surgeries, and due to lack of the subcutaneous tissue, outer surface of pinna is more prone to the frostbite. So through the fissures of Centorni, the infections from the parotid and the superficial mastoid region can reach up to the meatus. So here is the fissures of Centorni. And what is furunculosis? It is the inflammation of the hair follicles that's found in the cartilaginous part only. And otitis externa and the perichondritis are acute inflammatory conditions. We know otitis externa. Clinically, we will make it out by the tracheal tenderness. So in the middle ear, there is a Eustachian, is formed by the Eustachian tube. This is a Eustachian tube, the tympanic cavity, the mastoid antrum, the adductus and the antrum and the mastoid ear cells. So the developmental anatomy, the first pharyngeal pouch, the proximal narrow portion, Eustachian tube, distal dilated part of the tubotympanic recess forming the middle ear cleft. The osticular development, the first arch cartilage forms head and malleus and the body of the incus. The second arch forms the manubrium of the malleus and the long process of incus and cura of the stapes. The foot plate of stapes arise from the outer periosteal layer of the otic capsule, the middle and chondral layer of the otic capsule, the inner endosteal layer from the periotic mesoderm. The entire middle ear cleft is lined by the columnar ciliated and the pavement epithelium. Now let's talk about the middle ear spaces and the folds. The ossicles are enveloped by the mucosal lining between 3 to 7 months of the intrauterine life, forming the folds in the spaces in the tympanic cavity. So the attic compartments, there is the anterior and the posterior superior and the medial inguinal spaces. The compartment of the mesotympanic is the anterior and the posterior malleolar fold. Now here is a diagram. You can see the development of the mucosal folds. First, the Eustachian tube, the 3 to 7 months, this is the absorption of the gelatinous tissue. Then the development of the endothelial line fluid pouches. Then there is a budding out of the 4 primary sacs. What are those 4 primary sacs? These are saccus anticus, the saccus medius, the saccus superior, the saccus posticus. So from the saccus anticus, there is the anterior pouch of 1 troch and the supratubal space. Further lead to the tensor fold along with the saccus medius, which give the prosac space. Then saccus medius give the attic, the tympanic anticus, which further gives the anterior saccule, the anterior compartment of the attic, the medial saccule, the superior inguinal space, the lateral inguinal fold and the posterior inguinal ligament, and the posterior saccule, the mastoid ear cells. Then comes the saccus superior, which is the posterior pouch of the 1 troch, the inferior inguinal space, the pyramidal eminence on the antrum, and the tympanic posticus, which further the tympanic, the pars squamous, the corner septum arises. Then comes the saccus posticus, which lead to the origin of the round window niche and the sinus tympani and the oval window. Now let us talk about prosaic space. What is a prosaic space? It is a potential space bounded laterally by the sharpness membrane, the pars flaccida. Immediately there is a neck of the malleus, the superior there is a lateral malleolar four fibers, and inferior is a lateral process of malleus. Actually, the prosaic space is a potential space for the origin of the cholecystoma. Now comes the Eustachian tube. It connects the tympanic cavity with the nasopharynx. It is 3.6 cm or 36 mm in adults. Well, the upper 1/3 is bony while the 2/3 is cartilaginous. More horizontal and wider, shorter in infants. So from this pic you can see it subtends an angle of 10 degrees in children or infants, where it subtends an angle of 45 degrees in adults. So what are the basic functions of the Eustachian tube? The ventilation, it prevents the reflux and clearance of the middle ear secretions. Well, we need to know this because of this horizontal line Eustachian tube, and the length is also around 17 or 18 millimeter as compared to adults, in which the length is 36 millimeter. There are more chances of infection in children and infants. And middle ear pathologies, infections are more commonly seen in infants and children because of the smaller length 18 millimeter and lesser middle ear space and horizontal line Eustachian tube. So it is more horizontal, wider and shorter in infants. The nasopharyngeal opening lies behind the posterior end of the inferior turbinate. Now the ostomy pad of fat is a fibrofatty tissue that closes the Eustachian tube, protecting from the nasopharyngeal reflux. So what are the blood supply? Ascending pharyngeal artery, the middle meningeal artery, and the artery of the pterygoid canal. The venous drainage is by the pterygoid plexus. Now let us talk about tympanic cavity. It is a six-sided cavity and shaped like a biconvex disc. So you can see it is like a disc, biconcave disc. It is divided into three parts. So what are the three parts? The three parts are the epitympanum, the mesotympanum, and the hypotympanum. When we talk about the epitympanum, it is the attic region. It lies on the topmost region. So it connects the mastoid antrum via the adductus posterior superiorly and situated above the malleolar folder tympanic membrane. So the epitympanum, basically there is a connection from the epitympanum to the adductus to the mastoid antrum. So it is a pathway to the mastoid antrum through adductus. Whereas if we talk about the mesotympanum, there is a pars tensa. Just behind the pars tensa, situated middle to pars tensa, is the mesotympanum. Well, below the level of the tympanic membrane is the hypotympanum. So what are the walls? The walls of the middle ear, the lateral wall basically is the tympanic membrane and the portion of the squamous part of the temporal bone. When we talk about the medial wall, it separates the middle ear from the inner ear. So what are the structures that are present? Yes, on the medial wall are present the promontory, the bony lateral semicircular canal, the oval window, the round window, the facial nerve in the bony fallopian tube. So here is a diagram of the middle ear. This is the promontory, this is the tympanic plexus, this is the stapes, the foot plate, this is the pyramidal process, this stapedius muscle, this is the Eustachian tube, this is the tensor tympani muscle, this is the facial nerve. You can see the facial nerve. So the facial nerve come here, this is the first genu, this is the second genu, genu is the turn. So the first genu you can see, this is the horizontal portion, this is the vertical portion, and here it is existing from the stylomastoid foramen. Here you can see the mastoid air cells. Here you can see the prominence of the lateral semicircular canal. This is the internal carotid artery. Here is the jugular bulb, lies the jugular bulb. Now again we can see this is the walls of the middle ear. So in the middle ear, the walls you can see in the anterior wall that separates the middle ear from cavity from the internal carotid artery. So this is the internal carotid artery. So this wall separates it from the internal carotid artery, anterior wall. So the canal for the chorda tympani nerve. See, you can see the chorda tympani. What happens? The chorda tympani nerve, it is a branch of the facial nerve. It exits from the posterior wall, then it passes from the posterior wall, and then it leaves from the anterior wall to supply to the tongue, anterior 2/3 of the tongue for the taste, sensation and pain. Then comes the canal for the tensor tympani muscle. It attaches to the malleus. You can see this is the tensor tympani. Main function, it basically medializes the malleus. It is attached to the malleus. It medializes the malleus whenever there is a loud sound. Basically, it dampens the loud sound. So it prevents the injury to the inner ear by dampening the loud voice. It contracts on loud voice. So here is a Eustachian tube. You can see the anterior malleolar ligament also attaches an anterior tympanic artery. Now if we talk about the posterior wall, the upper part shows the opening of the adductus, and below the adductus there is a bony projection known as the processus pyramidalis or pyramidal process. So this is the adductus, this is the pyramidal process. From here comes the stapedius muscle attached to the stapes. What is the function? Same for the acoustic reflex. It dampens the loud sound. Then comes the vertical portion of the facial nerve, courses down the axis stylomastoid foramen. So you can see here is the vertical portion of facial nerve, and then comes the floor. There is a thin plate of the bone separate middle ear from the jugular bulb. So here the thin bone it's separating from the jugular bulb, and then comes the roof, the tegment tympani and the tegment antroy separated from the middle cranial fossa. This roof separated from the middle cranial fossa. Now let us talk about the contents of the middle ear. So the contents of the middle ear comes the malleus. First, it is the largest, 8 millimeters. So this is the malleus. This is the handle of the malleus. This is the anterior process, posterior process, neck and head. Okay. So it has head, neck, handle, anterior and the lateral process. And handle attaches to the pars tensa. So this handle is basically attached to the pars tensa. Well, the incus, this is the incus. What does incus has? Incus has a short process, the long process, the body, and the lenticular process. So what happens? The long process articulates with the head of the stapes. Why the lenticular process? And the stapes is the smallest. These are stapes. Is a 3.5 millimeter, has a head, neck, foot plate. So this is the head, neck. This is a foot plate, and these are the two cruras, the anterior and the posterior cruras. So the foot plate is held to the oval window by the annular ligament. Now the muscle, the tensor tympani and the stapedius muscle, the two muscles of the middle ear, both helps in acoustic reflex. Basically, it dampens the loud sound. So the tensor tympani, it inserts to the neck of the malleus, supplied with a branch of the mandibular nerve. Whereas the stapedius, it inserts to the neck of the stapes and supplied by the branch of the facial nerve to stapedius. When we talk about the nerve, the chordae tympani, this nerve is the chordae tympani, which is the branch of the facial nerve. As we know, it supplies the anterior 2/3 of the tongue, taste sensation and pain, general pain. And the tympanic plexus lies on the promontory. It is formed by the tympanic branch of the glossopharyngeal nerve and the sympathetic fibers around the internal carotid artery. When we talk about the vessels, so the plexus of the stylomastoid artery and the corticotympanic artery. So the mastoid, what happens to mastoid? That develops from the squamous and the petrous part of the temporal bone. The adductus and the antrum is a short canal connecting the epitympanum with the mastoid antrum. So we know that this adductus basically connects the epitympanum to the mastoid antrum. This is the adductus is the small opening which basically connects the middle ear epitympanum to the mastoid antrum. So the mastoid antrum, it is the largest air cell in the mastoid bone, and it's the most important bony surface landmark in the surgery of the mastoid bone, as it is a McEwen's triangle. So guys, what is the McEwen's triangle? Well, superiorly, if you see, there is a suprameatal or the inferior temporal line, and from the spine of Henle, there is a posterior wall of the EAC, a superior posterior wall of the EAC, and the line joining them. So that's the McEwen's triangle. So McEwen's triangle, superiorly there is a suprameatal crest, the anteriorly, inferiorly there is a posterior margin external auditory canal, and posteriorly a tangential line from the posterior canal wall cutting the suprameatal crest. So the mastoid air cells is located mainly in the petromastoid and the squamous part of the temporal bone. There are three types of cells according to the pneumatization. These are the cellular, the most common 80%, and diploic and the sclerotic. Now here you can see the pneumatization of the mastoid air cells, the enlargement of the temporal bone and the extension of the air cell system from the epithelial sac and the antrum occurs simultaneously. At the end of the first year, the mastoid process develops as a result of the contraction of the sternocleidomastoid. These are the various cells you can see in the mastoid of the temporal bone. You can see there is a sinodural angle. There are the cells, there are the periantral cells, the perisinus cells, there are retrofacial cells, the tip cells, the peritubal cells, the petrous FX cells, zygomatic, these are mastoid, the ventrum, so the squamous cells, sinodural cells. The clinical significance, the cornus septum. It is a persistent petrosquamosal lamina causes difficulty in locating the antrum. So you can see what is the cornus septum. Here you can see it is a petrosquamosal lamina. So this is the basically what happens when we drill the mastoid antrum. Sometimes we think that we have drilled the mastoid antrum, but we have just reached the cornus septum. It is a persistent petrosquamosal lamina lying just above the main antrum. So it causes a difficulty in location of the antrum. So the mastoid process does not form a significant elevation until the second year of the life. Therefore, the conventional post-auricular incision is avoiding the facial nerve is lying very superficial. So before second years, it is not advised to give a post-auricular incision as the facial nerve lies superficially. Now the blood supply is the middle meningeal artery, the maxillary artery, the ascending phalangeal artery, the stylomastoid branch of the posterior auricular artery, and nerve supply is by the sensories Jacobson's nerve. The lymphatic is by the preauricular and the retropharyngeal lymph nodes. The posterior surface forms the anterior border of the posterior cranial fossa. Important landmarks are the sigmoid sulcus, foveate fossa, operculum, internal auditory canal, and the superior petrosal sulcus. Thank you.